Thank you very much. Thank you for this introduction, and I'm happy to be here today in this Zoom meeting to speak about hemiplegic migraine, because as you just presented, this is one of my research topics since more than 25 years now, because I started studying hemiplegic migraine back in 1993. Wow. So I will try to explain what is hemiplegic migraine today. So first, my links of interest with some labs working in the field of migraine, but there is no link of interest related to this lecture. So hemiplegic migraine is a subtype of migraine with aura. So you all know that migraine has two main subtypes: migraine without aura, characterized by severe headaches with associated symptoms, nausea, vomiting, photo and phonophobia. And then migraine with aura, where the headache is accompanied or preceded by transient neurological symptoms. In typical migraine with aura, which concerns 5% of the population, the general population, the aura symptoms comprise visual symptoms, sensory symptoms, and speech or language disturbance. And in migraine with hemiplegic aura, in addition to these symptoms, there is a motor weakness during the aura. This motor weakness can be affecting one side of the body, the arm, the leg, the face, or sometimes both sides together. Hemiplegic migraine is characterized by two main things. It can be either familial, like here on this family tree. All the people in orange are affected by hemiplegic migraine. And it can also be sporadic, called SHM, when the patient is the only one to have hemiplegic migraine attacks in his family. The parents are unaffected. The second relatives are also unaffected, and they may have migraine without aura, but nobody has hemiplegic migraine except the index case. In familial hemiplegic migraine, a part of the families are characterized by a monogenic inheritance. And because of that, familial hemiplegic migraine has been a model to study genetics of migraine. And this is interesting because we believe that all migraine varieties, including hemiplegic migraine, which is uncommon, might share at least some common molecular mechanism. So to identify the genes underlying familial hemiplegic migraine may help to understand the more common varieties of migraine. However, despite the fact that familial hemiplegic migraine has a monogenic inheritance, that means that everything is explained by a mutation in a single gene for a given patient, familial hemiplegic migraine is characterized by a broad clinical spectrum with a marked phenotypic variability. That means that between various patients, the clinical features may be very different. And there is also a genetic heterogeneity. That means that there are different mutations in different genes that all can cause familial hemiplegic migraine. But these mutations explain only a part of the clinical feature. So a few words about the genetics of migraine. In migraine without aura and migraine with aura, the hereditary factors have been demonstrated by twin studies and family studies in the 1990s. And the global heritability is estimated to be between 40 and 50%. That means that if you have migraine, half of the cause of your migraine comes from the genes you have inherited from both parents. And this renders your brain sensitive to variations. And because of this sensitivity to variations, you are prone to have attacks of migraine without aura or of migraine with aura. The heritability is more important in migraine with aura than in migraine without aura. And these common variants of migraine are so-called polygenic. That means that accumulation of multiple variants in a high number of different genes, each having a minor effect, explains the fact that a person may have migraine attacks. In familial hemiplegic migraine, on the contrary, when it is autosomal dominant, then a pathogenetic mutation in a single gene is sufficient to produce the disease with a very high penetrance. That means that in large families, a father can transmit the disorder to half of his children, and a mother, an affected mother, can also transmit the condition to half of the affected children, half of her children. And then sometimes hemiplegic migraine attacks can also be part of the clinical spectrum of other hereditary neurological and neurovascular conditions. But in these cases, migraine attacks are only part of the clinical features, and patients with these rare disorders also may have strokes or things like that. So this is a picture of all the genes that have been identified in familial hemiplegic migraine. There are several genes that have been identified. 4 are major genes, and all these genes, they encode ion channels or ion transporters, which are important for the communication between cells in the brain, between different neurons, and also between the neurons and the glial cells. For example, here the astrocytes. Astrocytes, they rely blood to neurons, and they provide energy to the neurons. And then all the mutations implicated in familial hemiplegic migraine, they increase the susceptibility of the brain to what is called cortical spreading depression. And cortical spreading depression is a mechanism of migraine aura. It's a wave that usually starts back in the head on the cortex in the occipital regions, and then slowly progresses forward to the frontal part of the brain. And depending on the regions that are affected by cortical spreading depression, you have clinical symptoms of the aura. If it affects the occipital cortex, you have visual symptoms, and then when it progresses, you can get sensory symptoms, speech and language disturbances. And if the cortical spreading depression crosses to the motor era in the brain, then you may have a motor deficit. So this is a very busy slide, sorry for that, but sometimes hemiplegic migraine or other attacks of migraine may be part of a more complex condition causing other neurological symptoms like strokes and also migraine. Several disorders have been described since more than 20 years, but they are very rare. And today we will not speak about these disorders. we will speak only about familial hemiplegic migraine or sporadic hemiplegic migraine with mutations in the main hemiplegic migraine genes, coding for ion channels, ion transporters, and all this machinery here in the brain called the neurovascular unit, neurons, astrocytes linked to the blood vessels. In the more common varieties of migraine, migraine without aura and migraine with aura, more than 100 migraine risk variants have now been identified by very large genetic studies. The most recent study has been published in 2022. And you see this study involved more than 100,000 migraine cases and more than 700,000 controls. And this permitted to identify 123 loci, including 86 new. And these loci, they cover all the genes, all the genomes, all the chromosomes. And these loci, one variant is not sufficient to produce a migraine brain. You need to have not perhaps 100 or even more, 200 variants to be susceptible to migraine. And each variant in these more common migraine types, migraine without aura, migraine with aura, increase the susceptibility to migraine only a little bit. So you need to have multiple variants in order to develop migraine attacks. Some of these variants are expressed in the neurons and some are expressed in the vessels. Here you see a very beautiful slide of electron microscopy of a neurovascular unit. Here in lila, you can see the neurons. Here, this green cell with a lot of feet, it's an astrocyte. And here in red, it's a blood vessel. So the migraine genes, they are expressed in the neurons, in the astrocytes, and also in the vessels. So now we will speak only about familial hemiplegic migraine and sporadic hemiplegic migraine. And first of all, this is it's a very rare condition. In Denmark, there has been a large population-based studies on the whole 5.2 million inhabitants that showed that the overall hemiplegic migraine prevalence is 0.01% of the entire population. Half are familial cases and half are sporadic cases. In the literature, more than 200 families and over 200 sporadic cases have been published now, with an overrepresentation of large families and also of cases with associated manifestations, because people who study this prefer to present cases with rare and difficult to treat conditions more than patients with mild disorders that are easy to treat. And which appeared is that in hemiplegic migraine, migraine attacks are often associated with other transient or permanent neurological symptoms. And for example, permanent cerebellar signs, which are often associated with hemiplegic migraine type 1, is present in 20% of the published families versus only 4.5% of the Danish population-based families. And I will describe these symptoms in a few slides. Familial hemiplegic migraine and sporadic hemiplegic migraine have a broad clinical spectrum. People affected may have attacks of migraine with hemiplegic aura, that means with a motor deficit, in addition of other aura symptoms, They also may have migraine with typical aura. That means attacks with visual, sensory, speech disturbances, and sometimes what is called brainstem aura or basilar type aura with vertigo, tinnitus, difficulty to walk, etc. They may have other paroxysmal manifestations, and I will describe them. Sometimes they have permanent manifestations, and among families and among patients, there is a very important variability, an individual variability depending on age. Sometimes during childhood, the patients have a lot of attacks, and after they get better, and sometimes attacks can recur after 50 years of age or so. There is an important intrafamilial variability, and for example, a father affected by hemiplegic migraine may have a son who has a much more severe form than himself. And there is also an interfamilial variation. So it's always difficult to predict the severity that the condition will have. This is important, for example, for genetic counseling. So what are typical hemiplegic migraine attacks? The onset takes place during childhood or youth. However, there is a wide range, and I have seen patients with attacks starting below the age of 1 year old. And in the literature, I think that the older patient with onset of hemiplegic migraine was 75 years old. People who have mutations in the known gene have a lower age of onset than the patients without identified mutations. The mean frequency of attacks of hemiplegic migraine is usually low. People have 3-4 attacks every year. This is a mean, but this can be very variable, from 1 attack per day to only 2 in a lifetime. However, most patients after an onset during childhood get better after 25 or 30 years of age. And this improvement is spontaneous. It's not the result of a treatment. And this is because familial hemiplegic migraine is a disorder of cerebral excitability, and with brain maturation and with brain aging, this improves the condition. Triggers of hemiplegic migraine attacks are not the same than triggers of usual migraine without aura or with aura. Characteristic triggers are benign head trauma. For example, a little girl runs at school and bumps her head, and a few minutes after, hemiplegic migraine attacks may start. Conventional angiographies, like cerebral angiographies or coronarographies with contrast enhancement, may trigger attacks. And some patients report that exercise, fatigue, or stress may also trigger some of their attacks. Some studies have shown that patients with typical hemiplegic migraine are insensitive to the usual triggers incriminated in migraine without aura, like food or pharmaceutical triggers like nitric oxide or CGRP. You know that the newest migraine treatments involve a CGRP as a main target, because CGRP is liberated by the trigeminal system during migraine attacks. And if you inject CGRP to migraine patients, this will trigger a very severe attacks, attack in most of the patients with migraine without aura, and also in some patients with migraine with aura. But in typical hemiplegic migraine, the studies have been done in Denmark with volunteers who got CGRP injections, and this did not trigger a hemiplegic migraine attack in these patients. They are not sensitive to CGRP. In patients with hemiplegic migraine, the attacks, they are related to the mutation the patient is carrying, and it is the aura that starts all alone or because of benign head trauma or stress, and then the headache is triggered by the aura phase. So most familial hemiplegic migraine patients have a low level of vulnerability with less than 5 attacks per year and no identifiable triggers. The typical hemiplegic migraine aura is usually complex and prolonged. Complex because patients will have more than 2 symptoms, including weakness. So they have a motor weakness. The motor weakness can be mild, with only a difficulty, for example, to move the hand. And sometimes it's more important, with a difficulty to move the hand, the leg, and the face. And sometimes it's really hemiplegia. So hemiplegic migraine does not correspond to hemiplegia during all attacks in most patients. Usually, the patients, they start by having visual symptoms, then sensory symptoms, then they get the paralysis or the paresis, often affecting the limbs that are also affected by the sensory symptoms like paresthesia and loss of sensory feeling. And after that, they have speech disturbances. They cannot choose the right word, or sometimes they cannot speak. And after that, sometimes they also have basilar type symptoms like vertigo, tinnitus, and unsteadiness. The motor deficit may be unilateral, and in patients, it can affect always the same side, or sometimes it can switch sides between the various attacks. And in at least a third of the patients, the motor and sensory symptoms may be bilateral, not in every attack, but sometimes. And in some patients, it's the right side, and after that, the left side. In some other patients, it's opposite. And some patients have a bilateral motor and sensory deficit, starting, for example, in both legs, and then affecting both arms, and then coming up to the face. The mean duration of the aura is 3 hours per symptom, but this is also highly variable from 10 minutes with short auras up to 2 to 3 days. So if you have an attack and with a prolonged aura of 2 or 3 days of visual symptoms, speech disturbances, sensory loss, and paresis of the arm and the face, and if this is the case in each attack, it can be very frightening for the patient, for the family, and may induce a very poor quality of life if the attacks are frequent. For comparison with migraine with typical aura, in hemiplegic migraine, visual symptoms are less common. Headache follows the aura or starts during the aura and is mostly that of a typical migraine without aura. It's rarely absent, but some patients may have only the hemiplegic migraine aura and no headache at all. It's about 5% of the patients that have isolated aura. And when the headache is present, the mean duration is 24 hours, but it can last up to several days and be very severe with photophobia, phonophobia, nausea, and vomiting. So the cortical spreading depression in hemiplegic migraine, it's supposed to start here back in the cortex in the visual area and then to progress slowly at the rate of 2 to 3 millimeters per minute. And depending on the cortical regions that are affected, you will get the various symptoms. And if the cortical spreading wave crosses here this central region, here in front, it affects the motor regions. So there is a motor deficit. For the positive and negative symptoms depend on which cortical zone is affected. For example, for visual symptoms, one person may have positive visual symptoms like flickering lights or light spots. And what is called negative symptoms is a hole in the visual field or hemianopia. That means that one part of the visual field is lost. So this is transient, and some patients may have both positive and negative symptoms. In migraine with typical aura, cortical spreading depression may cease anytime after occipital onset. So that means that in migraine with typical aura, visual symptoms are the more common, and then sensory and aphasic aura concerns only a few patients and are not present in all attacks in most patients. In hemiplegic migraine, the sulcus centralis, which is here, does not block cortical spreading depression. So perhaps that cortical spreading depression in these patients may affect deep brain areas before reaching the motor cortex. Perhaps that the cortical wave is going down and then again up to the motor regions. And in hemiplegic migraine, there are no visual symptoms in 10 to 20% of the patients, suggesting that cortical spreading depression could start in the occipital cortex and become symptomatic only when reaching the sensory cortex with sensory symptoms, or that cortical spreading depression could start in the sensory cortex or in deeper areas. In hemiplegic migraine, the underlying cortical spreading depression exceeds the spatial and temporal propagation of cortical spreading depression underlying migraine with typical aura, so that the affected patients have more long attacks and more severe attacks, and aura is really a problem for them. And because of this susceptibility of cortical spreading depression in hemiplegic migraine, there is a risk of what is called severe attacks of hemiplegic migraine. So one can say that normal attacks of hemiplegic migraine are severe, and I agree, but the patients are at risk of more severe attacks. And what does it mean? That means that in addition to the typical aura symptoms, motor, sensory, aphasic, they will have an impaired level of consciousness. It can be confusion, agitation, but sometimes it's a loss of consciousness and a coma. So I have seen a lot of patients with coma induced by a severe hemiplegic migraine attacks, and sometimes these patients need intensive care unit for some days or some weeks until they recover a normal consciousness. In addition to coma, often there is an associated fever, which can be high, 40 degrees, 41 degrees, and meningeal signs. So when the patient, they come into the emergency department with a hemiplegia, fever, coma, then the physicians have to rule out first much more severe causes, like, for example, an infectious meningitis, before concluding to a severe attack of hemiplegic migraine. Sometimes the brain affected by the cortical spreading depression becomes swollen. This is shown on this MRI on the right part. Here you can see the brain is swollen, and on the other side, it's not swollen. So this patient had a deficit opposite to this brain region, and which lasted several weeks. In addition, the CSF may be abnormal, like in a meningitis, and these people, they have a slowing of the cerebral activity that can be recorded on electroencephalography. Such severe attacks are not common in hemiplegic migraine. Some patients have 1, 2, but some children may have frequent severe attacks, 1 or 2 every year during some years. And the motor deficit and the consciousness trouble may last up to some weeks. Sometimes this is the mode of revelation, of presentation of the condition. And in somebody who has no affected parents, and when it's sporadic, this may cause a diagnosis delay because physicians don't know very well hemiplegic migraine, and they will think to infectious causes, to autoimmune conditions, sometimes to stroke, and sometimes the diagnosis will take place only a few years after the first attack. Severe attacks with coma and fever may be triggered by head trauma, angiography, and may sometimes take place during pregnancy. Pregnancy is a cause of aggravation, transient aggravation of hemiplegic migraine in a woman affected by this condition. Full recovery is the rule, but previously, when the intensive care measures and support was not as efficient as nowadays, some fatal issues have been published. Personally, I have seen a lot of patients with hemiplegic migraine, and I'm glad to say that nobody had a fatal issue. But these patients need to go to the hospital to have investigations and to be placed in an intensive care unit until they recover. And the recovery is spontaneous, but can also be helped by, for example, administration of corticosteroids, IV corticosteroids, to reduce the brain edema. So in addition to hemiplegic migraine, patients with hemiplegic migraine attacks can have co-occurrence of migraine with typical aura and also of migraine without aura. This has been shown in the Danish population-based study. So in patients with hemiplegic migraine, the risk of migraine with typical aura is increased in the index cases, the probants, but also in first-degree relatives with or without familial hemiplegic migraine. But they couldn't show an increase of migraine without aura. So really, people who are affected by hemiplegic migraine and by the mutations in the causative genes, they have an increased sensitivity to cortical spreading depression. They are at risk of having severe hemiplegic migraine attacks, but they do not have more migraine without aura than the general population. This is also the case in patients with sporadic hemiplegic migraine. There is a marked increased risk of migraine with typical aura in probants with sporadic hemiplegic migraine, and also in their relatives, but not of migraine without aura. So sporadic hemiplegic migraine and migraine with typical aura are two clinical expression of the same underlying pathophysiologic mechanism in these patients with sporadic hemiplegic migraine. Sometimes they will have an attack where the cortical spreading depression reaches the frontal regions, explaining the motor deficit, and in some other cases, they will have a migraine aura that will stop before reaching the motor areas, and they will have no motor deficit. So in addition to migraine attacks, people with familial and sporadic hemiplegic migraine may have other associated neurological conditions. Epilepsy is among these conditions. epilepsy is independent from hemiplegic migraine attacks. It has been reported in more than 60 mutated cases in the literature, and with all the 4 known and identified familial hemiplegic migraine genes. There have been various types of epilepsies reported, partial or generalized seizures associated or not with fever. And often epilepsies has a childhood onset, sometimes before the first attacks of hemiplegic migraine. And these epilepsy in these patients have often a benign outcome. That means that the children will have benign seizures between the age of 2 or 5, and then at the age 8 or 10, they will begin to have hemiplegic migraine and they will stop having seizures. Sometimes it's the opposite, and hemiplegic migraine attacks takes place first during youth and continue in adulthood, and then the patient can start to have seizures when he's 25 or 30 years old. In the Danish population-based study of familial hemiplegic patients, 7% of them had epilepsy. So this is 7 more than 1% in the non-affected relatives. So familial hemiplegic migraine mutations may induce not only a susceptibility to cortical spreading depression, but also an abnormal brain excitability with abnormal neuronal discharges leading to epilepsy. Then there is a very rare phenomenon called elicited repetitive daily blindness. 2 or 3 families have been published with this phenomenon in addition to hemiplegic migraine attacks. It's a visual phenomenon that has nothing to do with a visual aura, and it's characterized by a short blindness, less than 10 seconds, that develops from the visual periphery to the center, followed by a refractory period of about 30 seconds. And people who have this phenomenon can have that a few times every day, or sometimes more, 20, 30 times. And it can be triggered by light changes, illumination, standing, or eye rubbing. And perhaps that this short phenomenon is caused by a retinal cortical spreading depression wave-like propagation. We don't know that because it's not very common. And then there are some families and some patients who, in addition to hemiplegic migraine attacks, may have permanent cerebellar symptoms. The cerebellum is responsible for a gait, for a steady gait. So if you have a disorder in the cerebellum, you will have what is called gait ataxia. That means that the people who have gait ataxia, they walk as if they have drink alcohol, but they did not drink alcohol. So they walk not very steady, and they may also have an ataxic speech. That means that their pronunciation is not very normal. It's also like somebody who is drunk, because if you drink alcohol, it affects the cerebellum. So if you have already seen a person having an acute alcohol intoxication, you know what is a cerebellar symptom. So people with familial hemiplegic migraine type 1 and having permanent cerebellar syndrome, they may have problems in walking, in riding a bike, or a problem for pronunciating some words. The gait ataxia may precede the first hemiplegic migraine attacks, and sometimes it's isolated. Here it is shown a family. All those who are in orange have hemiplegic migraine attacks. Those with they have cerebellar ataxia. Here, this woman, and you can see that the son here has hemiplegic migraine, but no ataxia and no nystagmus. Nystagmus, it's a movement of the eyes that you can see when you examine these patients. And here, this sister, she has cerebellar syndrome, but no hemiplegic migraine attacks. And this can be associated in the patients with an atrophy of a part of the cerebellum. That means that the mutations responsible for familial hemiplegic migraine type 1, they can give attacks of hemiplegic migraine, but they can also affect the cerebellum, and the cerebellum looks more thin, and the cerebellum does not function well and causes gait ataxia in these families and in these patients. And then there is a problem of uncommon, but it's clear that some patients in some families with mutations in the familial hemiplegic migraine genes may have a delay in language acquisition, also delay in motor acquisition, and some cognitive impairment, and some even have marked mental retardation. So this is very sad. This can occur, for example, in a little child from a parent who is working perfectly normal and has only a few attacks. And then, for reasons that are still unknown, he has 4 children. 2 are affected by hemiplegic migraine, and 1 has a severe form of hemiplegic migraine, often with recurrent coma and recurrent attacks and epilepsy, and has a delay in development. These neurodevelopmental delays are not common. They have a very low penetrance in familial hemiplegic migraine families, and in the literature and also in the experience we have in French in the genetic lab. Usually there is only 1 severely affected patient in the whole family, and there was only 1 family with FHM2 published in the literature where all the 4 mutated subjects had cognitive impairment. So this developmental delay is mostly diagnosed prior to the onset of hemiplegic migraine attacks and is not a consequence of the repetition of the hemiplegic migraine attacks. However, it has been published in the literature that some little children starting having severe hemiplegic migraine attacks can lose their acquisition, and developmental regression was sometimes observed in a few cases of little children after the onset of very severe hemiplegic migraine attacks. And because of this severe outcome, it's we physicians have to be very cautious for the genetic counseling in familial hemiplegic migraine and sporadic hemiplegic migraine, because we know that depending on the affected gene and the mutations, there is a higher risk of these severe clinical features. So these are the 4 main genes that have been identified in familial hemiplegic migraine. The first one is called CACNA1A. It encodes a calcium gene channel, so a protein that is an ion channel to calcium. The second gene is a sodium-potassium pump expressed in astrocytes. The third gene is a sodium channel, and the 4th gene that was mainly studied in France is a small molecule called PRT2, which is helping the calcium channel gene to do his work. So all these 4 genes can be mutated in various patients, and if you have a test to determine what is the cause of hemiplegic migraine, then all these 4 genes are going to be tested. These genes are all implicated in familial hemiplegic migraine, but they are also implicated in other genes. So for example, for the calcium channel gene, it is responsible for familial hemiplegic type 1, but other mutations can cause episodic ataxia, That means these affected patients, they have attacks of gait ataxia, and sometimes in the middle of the day, and without having drunk any alcohol, they walk and they speak as if they were drunk. Another mutation here in the end of the gene can cause a progressive ataxia of late onset. And then other mutations in this gene can cause very severe neuropediatric manifestations called epileptic encephalopathy. Then in this gene, ATP1A2, it has been described in a family with migraine with brainstem aura. The sodium channel gene was identified in familial hemiplegic migraine type 3 in 2005, but it was previously known as a very important gene for hereditary epilepsy. And then PRRT2 is a gene involved in familial hemiplegic migraine, but other mutations can also cause epilepsy and movement disorders. So depending on the mutation you have, you can have various clinical manifestations. And that means that a part of the clinical phenotype is explained by the mutation. However, when I examine a patient and I ask questions to someone who is affected by familial hemiplegic migraine, I cannot determine from the clinical features of hemiplegic migraine attacks if it's going to be a mutation in the calcium channel gene or in the sodium channel gene or in the other genes. So sometimes to guide the molecular diagnosis, we can rely on the associated features, but hemiplegic migraine attacks are similar in patients across these various gene mutations. What is the role of the known genes in FHM? So here in this cartoon, you have a study of 230 index cases addressed for molecular diagnosis of hemiplegic migraine. And these patients were recruited in New Zealand and in Australia. And you see that for 2/3 of the patients, despite a large molecular screening, any mutation was identified. The calcium channel gene is the most frequently involved. No, it's not the most, it's ATP1A2, FHM2, which is the most common, followed by the calcium channel gene. And then the third gene and PRT2 are responsible for a few patients. Other mutations have now been identified in other genes, but need to be confirmed. Here, this is a result of the study in France on a much larger panel of patients addressed for suspicion of hemiplegic migraine. This is a cohort of 697 patients since some years. And you can see that no identified mutation was found in 85%, and that the main gene is ATP1A2, 6% of the patients, followed by CACNA1A, the calcium channel, followed by PRT2 and the sodium channel. So in 15% of all the patients sent for molecular diagnosis, we can identify a gene and we can find a mutation and be confident in the genetic diagnosis. And in the other ones, familial hemiplegic migraine and sporadic hemiplegic migraine may be linked to other genes that have not been identified at this time, or may be due to mutations in a combination of genes. So the role of the known genes in sporadic hemiplegic migraine was minimal in the Danish population-based cohort. They had about 100 cases and only 2 had ATP1A2 mutations and the other one no identified mutations. The role of the known genes is limited in index cases affected by pure sporadic hemiplegic migraine. That means people who have only hemiplegic migraine attacks, no epilepsy, no ataxia, no cognitive problems. But it is high when the age of onset of hemiplegic migraine is early, below 16 years of age. If hemiplegic migraine attacks start in childhood or in early adolescence, then the risk or the chance of identifying a mutation in the two first genes is elevated. This is also the case when hemiplegic migraine is associated with other manifestations like epilepsy, delayed speech, or with cerebellar ataxia. So what is the outcome of sporadic hemiplegic migraine? This is also a study published by the Danish team. They have followed 18 patients with sporadic hemiplegic migraine at baseline and after follow-up. And the diagnosis was unchanged in 14. And in 4 patients, the diagnosis turned to be familial. So first, at the first examination, the patient was the only one in his family to have attacks. And a few years later, after follow-up, perhaps he has a child or another affected patient in the family. And then sometimes the attacks can stop after a while. Sometimes the patients, they have no more familial hemiplegic migraine attacks, but they have only attacks of migraine with typical aura. And sometimes they stop having a migraine and they have only a migraine with aura, and they have only migraine without aura. So the diagnosis can change after some years. It's not fixed. So for sporadic hemiplegic migraine, there is perhaps a greater heterogeneity even than in familial hemiplegic migraine. Some cases are truly non-inherited cases where the mutation appears de novo in the patient. This is represented here. You have the mother without any mutation, the father without any mutation, and here the boy is mutated because at early stages of development, a mutation appeared. And then this mutation will be possibly transmitted to half of his offsprings. Sometimes familial hemiplegic migraine has a reduced penetrance. And here, if this grandfather died early, here his son does not know that the father had some attacks of hemiplegic migraine. In some patients, they have only 1 or 2 attacks in the whole life. And then here, the boy has hemiplegic migraine attacks, but nobody knows anymore in the family that the grandfather have had some attacks. So it is appearing as sporadic, but if genetic tests are done in the parents, you will find the mutation in the boy and the same mutation in the father, who carries the mutation, but the mutation is not expressed and the father has any attacks. And then sometimes perhaps that hemiplegic migraine can be the result of polygenic inheritance, like the more common forms of migraine with aura. And then there are some studies and some publications of patients who did not have migraine with aura during childhood or during early adulthood. And then these patients, they start to have migraine attacks, normal migraine attacks without aura, sometimes migraine with aura. And later in their life, they develop attacks of familial hemiplegic migraine, sporadic hemiplegic migraine. And this has been studied in veterans, US veterans after Iraq war. And in the army, they were confronted to a huge number of soldiers coming back from Iraq or Afghanistan and who developed symptoms of migraine with hemiplegic aura. So perhaps that trauma, psychological trauma or abuse, can trigger hemiplegic migraine attacks that start later in adulthood. And the mechanism of these attacks are unknown. Is it a cortical spreading depression, or is it possibly a functional disorder, like, for example, was seen after World War I a lot with patients, soldiers having abnormal movements and variety of neuropsychological manifestations that was related to trauma. So I have some patients with hemiplegic migraine, which are sporadic, and who started after severe life events. And they have to be diagnosed and treated like the other patients. But in addition to the treatment for attacks and to the preventive treatments, they need also more psychological care and to be taught about the link between the bad events they have in their lives and the manifestation they have, in order that they can be more resilient, if possible, and to improve. So there are some genotype-phenotype correlations. In familial hemiplegic migraine type 1, the onset is early, 12 years in mean. Patients are at risk of having severe attacks with coma. They have cerebral ataxia in 60% of the cases, sometimes epilepsy, sometimes cognitive impairment and mental retardation, and they are at risk of severe attacks with coma. In FHM2, onset is young. There is a risk of severe attacks. Epilepsy is very common. Cognitive troubles are possible, and ataxia is very rare. In the sodium channel mutation, people have hemiplegic migraine attacks. They have epilepsy in numerous cases, and they have also these bizarre short visual symptoms. And then in patients with PRT2 mutations, the onset is below the age of 16 years of age. They can have epilepsy, then they can also have abnormal movements, like attacks of dystonia or what is called a paroxysmal kinesiogenic disorder. These are patients, if they try, for example, to run, then sometimes, not always, they can have an abnormal movement of the legs triggered by the movement, which lasts a few minutes and which is impairing the movement. And people with PRT2 mutations, they can also have hypersomnia and also mental retardation. And in familial hemiplegic migraine without an identified mutation, that means they have no mutation in the calcium channel, in ATP1A2, in the sodium channel, or in PRT2. Severe attacks are very uncommon. Hemiplegic migraine is often associated with migraine with typical aura. They can have epilepsy, but the risk of epilepsy is 7% of the patients compared to 1% in the general population. And age of onset is sometimes during early adulthood or more later. So the one problem for clinicians who take in charge the families with hemiplegic migraine is a clinical variability. So I would like to present you a small family, which I know since 30 years. So the father here, he's now a little more than 54 years old. He has a normal examination. He has 5 typical hemiplegic migraine attacks between 16 years of age and 22. Then he had a free interval of 32 years. He works normally, and he forgot that he has hemiplegic migraine. But at the age of 54, he has an attack again with vomiting, fever, confusion, and right hemiparesis during 48 hours. So it was a recurrence after a long free interval of hemiplegic migraine. And he has a son. The son is now more than 26 years old because the slide was made a few years ago. And this son has ataxia. He had a delayed development of gait. He also has a marked mental retardation. He cannot live alone. He is in an institution. And he has hemiplegic migraine attacks, typical ones that started at the age of 4. and typical attacks continue to the age of 23. But every year, he has at least one coma with fever, prolonged hemiplegia, seizures, then followed by confusion and sometimes hallucination during several weeks. And he needed at each time to be hospitalized. And then at age 22, he started, in addition to hemiplegic migraine attacks, to have partial epileptic seizures with secondary generalization that continued and that were controlled by medication. And actually, epileptic seizures in these men are more common than hemiplegic migraine attacks. So you have the two patients, they have the same mutation. One, the father is living almost normally, and the son needs a continuous support because he cannot be autonomous. So for the genetic counseling, it's very important to always have in mind that a patient like this one can have normal children and can also have children that will have a very serious condition. So the diagnosis of familial and sporadic hemiplegic migraine may be a challenge. We rely on clinical features. So to make the diagnosis, it requires to have at least 2 attacks. Diagnosis can be made at the first attack if there is a family history or if the genetic tests are positive. And then the other neurological features have to be consistent with familial or sporadic hemiplegic migraine. That means you can have hypersomnia, epilepsy, ataxia, but in hemiplegic migraine, there is no risk of early stroke, for example. And the brain MRI, the brain imaging, except of the swelling during severe attacks or except of the atrophy of the cerebellum, is normal. And then we rely on the familial history in first and also in second degree relatives. Clinical imaging examination done outside of an attack is usually perfectly normal, except sometimes for cerebellar syndrome. And investigations are normal in attack-free periods, except for cerebellar atrophy in some cases of familial hemiplegic migraine type 1. There are no white matter abnormalities and there are no signs of stroke on brain MRI. During attacks and during severe attacks, investigations may be normal. Imaging can show a swollen brain, edema, cortical edema. Electroencephalogram can show a slowing of the activity of the brain that may persist sometimes for days or weeks after an attack. And CSF may be abnormal with elevated white blood cell count in the CSF. And this can lead to false diagnosis of meningoencephalitis, infectious or dysimmune meningoencephalitis. So this renders a diagnosis difficult if there is no family history and if it is a first attack. Because when there is a severe attack, it's very important for the clinician to make a differential diagnosis and to be sure that it is a hemiplegic migraine attack and not another cause, like for example stroke or a seizure or an infectious cause or toxic or metabolic causes. So investigations in these cases are important, and if there are some abnormalities, they will normalize in hemiplegic migraine after a few days or a few weeks. And sometimes hemiplegic migraine can occur in people who have other even more severe conditions. For example, hereditary vasculopathies like CADASIL or amyloid angiopathy, etc., can cause attacks of hemiplegic migraine or other types of migraine when the persons have 15, 20, 25 years. And after 15 years more, then it will cause strokes. So this is not the same condition. So patients with FHM having a severe attack need to go to the hospital and need to have investigations, because in these patients, any adverse event that the patient can have may trigger a severe migraine attack. For example, if a patient with hemiplegic migraine has infectious meningitis, then the infectious meningitis will manifest with the symptoms of infectious meningitis, but also with a symptom of a severe hemiplegic migraine attack. This is a possibility I have seen a couple of times in my clinical practice. So to help the diagnosis, there is a molecular diagnosis that can now be made very easily. In France, there is one lab, and so the blood is drawn from the patient after informed consent. And for the children, we also take the blood from the parents, and then it's analyzed. If we find a mutation known to cause a condition, then the diagnosis is sure. If we don't find a mutation, then it means that it may be hemiplegic migraine, but without an unidentified mutation. The genetic screening has technical limits, but also has an incomplete sensitivity. So the molecular diagnosis, I've already shown you in the French cohort that the rate is only 15% with all these genes, so that most of the patients, they have no identified mutations, but this is better for them because patients without identified mutations in the 4 main genes, the clinical features are milder than in the people with the known mutations. Usually there is no mental retardation, no risk of severe attacks, or lower risk of severe attacks, and the outcome is more benign. So how can we treat familial and sporadic hemiplegic migraine? So there is no any difference in the treatment proposed for the sporadic and the familial forms. Treatments like in other varieties of migraine may be prophylactic or symptomatic, but there is a low mean frequency of hemiplegic migraine attacks, only 3 or 4 per year. So sometimes no preventive treatment may be a choice. And because of the rarity of familial hemiplegic migraine, there are no large series of patients and no therapeutical trials. So the therapeutic options are strictly anecdotal accounts that suffer possible base or that have been included in larger series of migraine subjects without various non-hemiplegic manifestations. And so the management of familial and sporadic hemiplegic migraine is mostly based on what is known about the other forms of migraine with aura. For the attacks, it has been published that some rare cases observed a reduction of aura severity and duration after the administration of intranasal ketamine, but you see, it was only in 5 of 11 patients. IV naloxone in 2 patients, IV verapamil in 1 patient, but in another, this same treatment caused a seizure, and IV dihydroergotamine. Actually, severe attacks are in fact treated with a support, IV analgesics or aspirin or NSAIDs, antipyretics, antiepileptics if there is a seizure, oxygenotherapy, ICU admission, and now high doses of IV corticosteroids seem to be effective in reducing the cerebral edema, which is ongoing in severe attacks. For usual attacks, analgesics, aspirin, and NSAIDs can be used for the headache. Nothing can stop the cortical spreading depression. Vasoconstrictors are not indicated, triptan and ergots, but are often used in patients with hemiplegic migraine who are more impaired by the headache phase than by the aura. Sometimes I prescribe triptans to these patients. I tell them to wait until the aura is finished, and then if the headache is bad, they can take a triptan. But in a severe attack, or in case of a prolonged aura, if you have hemiplegic migraine, it's better not to take the vasoconstrictors because the cerebral edema in prolonged attacks or in severe attacks is associated with various caliber changes in the brain vessels. Sometimes the caliber is increased and sometimes it's reduced. So it's better not to take vasoconstrictors. And then for the prophylactic treatment of hemiplegic migraine, all prophylactic agents used in migraine without aura or migraine with aura may be tried. Propanolol, which is a beta-blocking agent, may be tried, but there are some concerns about the possible aggravation of migraine aura. Sometimes I prescribe it. For example, in patients who have frequent migraine without aura and rare attacks of hemiplegic migraine, propanolol may be a good choice. Verapamil, which is a calcium channel blocker, was given to a few published patients with efficacy in the paper. After that, I tried it in 5 or 10 patients and I never observed any improvement. Acetazolamide may be prescribed to patients who have a mutation in the calcium channel gene because acetazolamide is very effective in other conditions due to CACNA1A mutations, such as episodic ataxia. So I tried this in some of my patients. And then the more effective treatments are anti-epileptics, also efficient in the prevention of migraine without aura. For example, sodium valproate, that can be given to men, but not to women of childbearing age because it's a teratogenic agent. Topiramate or gabapentin can also be tried. Then in the patients with PRT2 mutation, carbamazepine may be a good choice. And then in my practice, lamotrigine is the most efficient preventive agent in hemiplegic migraine and also in migraine with frequent aura. There were 2 studies that shown a 50% reduction of aura frequency in 75% of the patients. The cohort was of 58 patients with migraine with aura and 8 had hemiplegic migraine. I've treated more than 8 patients with hemiplegic migraine with lamotrigine, and usually it reduces the frequency of aura, and it may also reduce the duration of aura, and it may also shorten and reduce the number of symptoms during the aura. For example, a lot of my patients, after being treated by lamotrigine, they have migraine with visual aura, but they do not have any more sensory or speech or hemiplegic aura. So to conclude, hemiplegic migraine is a rare condition. There really needs to be a motor deficit, that is a loss of strength of one part of the body during the attack, and 2 attacks at least in order to make the diagnosis. In patients who have a mutation in the known major genes, the 4 major genes, there is a high penetrance in the familial forms, there is a high frequency of prolonged attacks, there is a risk of coma, and there is a high frequency of other permanent and paroxysmal symptoms, and the mean age of onset is low. And in the other patients who are much more common, who have no mutation in the known genes, it may be a low penetrance in familial form. There is no or rare prolonged attacks with coma. It's often associated with migraine with typical aura. There is a risk for epilepsy, but not so common. The mean age of onset is about 18 years of age. It may be caused by other dominant mutations that are still unknown, or of recessive mutations, or in these cases, hemiplegic migraine may have a polygenic inheritance. And then I should have added a line here about the sporadic hemiplegic migraine attacks, or sporadic hemiplegic migraine-like attacks that occur sometimes in persons who are submitted to psychological trauma, like war or like adverse events or abuse, and in which the pathophysiology should be studied more in depth. So this is my final slide, and I will be happy to answer your questions. Thank you very much.